Welcome back, listeners, to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas.
And my name is Alastair, and I'm a cardiologist in the United Kingdom.
Today's episode features a longtime friend of the podcast, Dr. Jonathan Weir McCall. Jonathan is an associate professor at the University of Cambridge and honorary consultant in cardiothoracic imaging at Papworth Hospital. He was a member of the first cohort of the SCCT Future Leaders Program and has gone on to contribute to both SCCT and international guidelines on the use of cardiac CT. He has long-standing research interests in cardiovascular imaging, particularly in the use of CT and MRI to understand cardiovascular disease, guide management, and inform prognosis. He will be providing us with a deep dive into some of his latest research, which was published in JACC Imaging earlier this year. The focus of that research is the national trends in coronary artery disease imaging in the United Kingdom, with focus on costs of testing as well as healthcare outcomes. Jonathan, welcome onto the podcast.
My pleasure. Fantastic to be joining yourself and Alastair.
Thanks for joining, Jonathan. Let's dive into some of that exciting research, shall we? So, for our listeners who are fans of the podcast, and for those who are new, guidelines in the US and Europe have acknowledged the vast body of evidence supporting the primacy of a non-invasive anatomical assessment of coronary arteries. And coronary artery CT angiography is considered to be a high-value imaging approach in patients presenting with undifferentiated chest pain. The United Kingdom was one of the first adopters of this growing body of evidence, and the NICE Clinical Guideline 95, NICE is the UK body which evaluates the cost and efficacy of healthcare pathways. They came to the conclusion that coronary CTA should be the first-line test as early as November 2016. And we have had a bucket load more trials, registries, and high-quality science since 2016 advocating the strengths of coronary CTA. So, Jonathan, the question we all want to know the answer to is, were the guidelines right to recommend coronary CTA as the first-line test?
Thanks, Alastair. I think the first question, before we even reach that point, is, does anyone even listen to guidelines? After all, guidelines are written by a group of august figures in ivory towers, and these may not represent those who are working down on the shop floor. And if the States is anything like the UK, there's minimal feedback loops to reinforce the guidelines recommendations, meaning that you're not punished or rewarded for following one particular guideline. And in fact, there was a nice survey in the UK in 2018 whenever they asked cardiologists what guideline they were following. And only a quarter said they were following NICE guidelines, whereas a third said they were following the European guidelines. And a third said they were not following any particular guidelines at all. So you'd think that with all the effort expanded on guidelines, the evidence supporting the impact they have would be better. But the closest we have prior to the current paper was an examination of the statin guidelines back in 2018 or 2019. And they showed that following the release of the updated statin guidelines, adherence to best practices for statin prescriptions increased from 18% of people being appropriately prescribed statins to 2 years later, 20% of patients being appropriately prescribed statins. So not a ringing note of success. So it was partly on this foundation that led us to start off this study. And I have to say, it's been a real labor of love. This actually started back in 2018 whenever I was undertaking my fellowship in Vancouver, and I got a phone call from Ed Nicol, who's the senior author of the paper, who said he'd just been chatting with NHS Digital, which is the organisation in the UK responsible for pooling all the health records across the hospitals in the National Health Service, and said that they'd started collecting imaging data over the preceding 5 or 6 years, and this was now being made available to the wider community outside the government. And we therefore thought that this would be an ideal opportunity to investigate whether the NICE guidelines had actually had an impact or not. So what we started off by doing was simply looking at what were the trends in cardiovascular imaging use over the 6 years between 2012 and 2018. And for the listeners that are unfamiliar, the NICE guidelines kicked into effect or were released to the general public in November of 2016. So essentially we had 2 years data after. Now, whenever we looked at the entire study period, we could see that the use of cardiac CT was growing quite pronouncedly, with a reduction in the use of SPECT and stable use of invasive coronary angiography. However, stable use over a study period or growing use over a study period doesn't actually mean the NICE guidelines have had an impact. After all, they could just have come out and people were already going to increasingly use CT. After all, Scott Hart came out in 2015, and as Alastair says, the volume of evidence supporting the use of CT has been slowly accumulating over the years. So what we did was we looked at the rate of growth pre and post the NICE guidelines and saw a very nice step change in the use of cardiac CT following the guidelines, showing that these did have a genuine impact in the utilization of imaging and the investigation of chest pain across the study period, which was very rewarding to see and very interesting as well, looking at the growth of use of cardiac imaging. Because the second thing we noticed was that over the study period, the use of cardiovascular imaging was going up by about 10% a year over the duration of the study period, so quite pronounced growth. So back to the original question from Alastair, did the NICE guidelines get it right? To those unfamiliar with the NICE guidelines were predicated on the most cost-effective approach to the diagnosis of coronary artery disease. It isn't about healthcare outcomes, it's not about management decisions. The one question that NICE asked was, what is the most cost-effective approach to the diagnosis of coronary artery disease? So we looked at the healthcare costs across the study period. And what we found was that despite the fact that imaging had grown substantially over the study period, as I mentioned before, there was an annualized growth rate of about 4%, with a 25% growth rate in CT. The study showed that the growth rate in costs came in just above inflation. So the costs for the healthcare system grew at 3% per year, despite this much higher rate in the growth of imaging. And over the same study period, inflation accounted for a 2.5% growth per year in costs. So, e.g., despite the growth in use in imaging across the study period, because of the greater use of a low-cost cardiac CT versus the high-cost SPECT and invasive angiography, this growth in the use of imaging was cost-neutral from a healthcare perspective. So, from NICE's perspective, they were exactly right. They showed that the use of cardiac CT for the diagnosis of coronary artery disease was and is the most cost-effective strategy to this. But I think a more epistemological question is, were NICE right in the first place? Not were their conclusions to their own particular question right, but is this the right way to define a guideline for a population? Should we not be focusing on management decisions and healthcare outcomes rather than simply the cost to diagnose? After all, in the Scott Hart arm, we saw that the rate of MIs was reduced by 50% in the CT arm compared to the standard of care arm. So this then took us on to the next step of the study, where looking beyond the NICE guidelines, we wanted to ask, are these actually having an impact on healthcare outcomes? Are the same beneficial treatment effects that we saw in the Scott Hart trial being realized in the real world? Now, this is a difficult question to answer using observational data, even whenever you're looking at a data set the size that we were. After all, there were approximately 1.9 million imaging examinations within the study cohort that we're looking at over the 6 years. Even within this size of cohort, it becomes very complex to untangle cause and effect and the relationship between two different variables. To try and tackle this, we undertook a natural experimental process. Now, we don't do a lot of this in medicine. However, within the world of economics, this is a standardized approach to try and understand what is the effect of changing the minimum wage, what is the effect of financial stimulus. You can look at these natural experiments that are brought about by larger structural environmental changes to try and determine the impact they are having on the population. So to try and design a natural experiment within this study population, we divided the country into 42 healthcare regions, rationing that the change in practice in each of these centres was going to be independent from one another. After all, one hospital getting a CT scanner doesn't change the likelihood of another hospital getting a CT scanner. And the timing of those are going to be very different. The speed at which people are able to increase their access to technology or expand their services is driven by a variety of random variables, all occurring down at that hospital level. So over the 6 years of our study, we compared these 42 healthcare regions, and what we looked at was how the use of CT was changing within each of these regions. And we looked at what was happening in terms of hospitalizations and cardiovascular and all-cause mortality in each of these regions. And whenever we broke it down by these factors, we found that regions in which cardiac CT was growing the most rapidly were also the ones that saw the most rapid fall in cardiovascular mortality. We also saw a trend towards the exact same outcome being observed in all-cause mortality, although this was not significant with a p of 0.07. So it certainly appears from this observational natural experimental design that the effects that Scott Hart would have led us to believe were going to be found in the general population are indeed acting out at the wider scale.
Jonathan, when Alastair asked you the question, I expected an idea as to the study design and the highlights from the main takeaways, but what we got instead was perhaps a PhD thesis level dissertation on the combination of the data and the philosophy behind cardiovascular disease specific to a region in the context of healthcare economics, all while realizing how a new imaging technique interplays between patients, hospital organizations, and guidelines writings committee. Thank you very much. So comprehensive. And now the next question is begged. How confident can we be about this association between the increased use of coronary CT in the UK or just in general and reductions in cardiac mortality? Is this a cause-effect relationship?
Excellent question there, Praveen. And it's the eternal question that comes out of any observational study. How far can we take our observations towards causality? Because we know correlation doesn't equal causation, but for causation to occur, there has to be a correlation. So out of all the correlations we see, which are the ones that are actually causative? And that's partly why we didn't simply go for a correlation at any time point or across regions. We were really looking for trends over time to try and extract slight regional differences that may occur in a variety of factors. But despite all that fact, we can get a strong signal from this. But if it weren't for the fact of the likes of Scott Hart, I'd be far more cautious in my support of the findings of the trial. But because we already have the top tier evidence of a large multi-center randomized controlled trial telling us that these are the effects that we would observe, what I see this study is doing is confirming that the benefits we would expect to see from the use of this technology are being actualized in the real world. Because there are many ways in which technology can fall short of its anticipated benefits. There are translational gaps, both from basic research to clinical science, but also between the clinical trials and clinical practice. It might be that David Newby and the team in Edinburgh were exemplary at chasing up all their patients and encouraging them all to take their statins and their aspirin and ensure that they were adhering to these based on the findings of CT. And if this wasn't taken up by the general population with the same gusto and enthusiasm, then the potential benefits of spotting atherosclerosis at its preclinical stage might be lost in the real world. So from my perspective, I see this, as I say, as a confirmation of real world benefit rather than proof in its own right of a causative effect.
Jonathan, just to follow up on that point, there are lots of confounders that we need to consider in terms of overall healthcare delivery. This was occurring at a time when primary percutaneous coronary intervention was being brought in for the treatment of ST elevation myocardial infarctions. There was more widespread use of primary prevention, with our general practitioners adopting, cardiovascular risk scores to increase, the use of statins at lower thresholds. And we obviously had, a change in our services with, rapid access chest pain nurses coming in. So, do you think we can really place the weight on CT driving this effect over and above those other confounded conditions?
It's an interesting question, and it's genuinely challenging to unpick these. One of the reasons I think it's likely true is CT is in no way linked to any of these individual factors. Why would the growth of CT in regions correlate with the GP's primary prevention? What does the installation of a primary PCI cath lab have to do with the installation of a CT scanner? After all, both of these other metrics are going on across the population in parallel, but there's nothing linking them in time. You could make an argument that better resourced places perhaps installed CT earlier and may have installed their PCI pathways in an earlier manner as well, so therefore that these two could occur in parallel. But if one was to expect that, if one was to use that as an argument, one would also expect to see the same relationship between the use of MRI and the outcomes, because MRI is an even more expensive investigation. It's more time consuming. So only the best resourced units could really expand their MRI service rapidly. But we saw no such correlation between the growth of use of MRI and cardiovascular outcomes. Now, there is the possibility that, as we said before, CT growth was induced by NICE guidelines, and it could be that centres that follow the NICE guidelines were also better at following the other guidelines. So I think this is the one confounder that we still need to unpick. Is the growth of CT simply a marker of the ability of a unit to follow national guidelines? And I believe this is hard to unpick, and this is a confounder that remains to be examined.
So just to follow up on that, Jonathan, one of the things that's intrigued me about the data that you presented was the heterogeneity across the UK in terms of, one, both non-invasive imaging modality delivery, and that being related to, differences in terms of the outcomes that have been experienced within those regional trends. Looking at the table that you had for differences, there were clearly lots of people who invested quite heavily in CT where they had no change in outcomes, and similarly centres which made no changes to their CT provision, which had quite marked reductions in modalities. Did you consider excluding the outliers to see what the overall trend would be in terms of whether there was a really quite strong effect between CT use and reduction in all-cause and cardiovascular mortality?
Yeah, it's an excellent thought. It was something that we had to look a lot at within the study for the exact reasons that you identify. And we targeted this through a couple of different techniques. One of them was through the use of the Thiel-Sen regression rather than our standard linear regression. And in the Thiel-Sen regression, you can have 70% outliers and you'll still derive robust estimates of the interacting effects. So we didn't need to exclude them because they have only a small impact on the trends. The second one was whenever we were looking at the association between imaging and outcomes, we used the Kendall rank sum test. And again, because this ranks them, each data point only accounts for a single place in the rank. So even extreme outliers are contributing the same amount of data as the non-outliers, so again have no opportunity to significantly skew the association or outcomes.
Jonathan, I want to talk more about that heterogeneity across geography that you have been mentioning. A lot of colleagues here in the United States are very familiar with the local trends in clinical practice. So, for example, I service a couple of local hospitals, some of which are rural hospitals, and we have ideas through varieties of techniques of data collection, namely QI, as to what sort of downstream events and downstream benefits we gain from particular decisions in cardiovascular imaging or cardiovascular care. One particular example that I can note is decision to purchase an additional scanner in a small rural hospital. The idea was to have information from our cardiology clinics with regards to which types of patients would be eligible for getting advanced cardiovascular imaging and how the downstream care within that local healthcare system would be affected from the purchase and installation of a new scanner. Now, granted, this is all very local. It's quite difficult to get more data beyond just, honestly, the state level in the United States. Even at the national and state levels, the data that we're collecting that are readily available are through Medicare and Medicaid, which do not account for the entirety of patients that receive care in the United States, not even more than a majority. So for this reason, with the perspective you have in mind of collecting national and regional data, how important is it really to collect that national information about cardiovascular imaging and its relationship with cardiovascular disease? Does it have a substantial impact on infrastructural investment or workforce planning outside of healthcare economies like the UK?
It's fascinating question, and it's also amazing the differences in the approaches between the countries and the opportunity for learning between them. I think the UK setup is not completely unique, but fairly unusual in the world through its National Health Service. The current study collected data within the National Health Service, which of course excludes a small percentage of patients who get their care through the private service, but this is less than 10% of the population, or less than 10% of the care within the UK. I think these kinds of data are incredibly useful at multiple levels. Like you say, it's very useful for looking at regional service development, service improvement, infrastructure, but also it provides unique opportunities to answer questions that are traditionally very hard. For instance, within the paper that we're discussing now, despite the phenomenal work of the Scott Hart team, their outcomes were entirely driven by non-fatal MIs. Despite a RCT of 4,000 patients, they still, after 5 years, did not have sufficient numbers to comment on the impact of CT on mortality. Once we're talking about population sizes of 1.9 million, we're able to start looking at these effects in a much more granular manner, and also to measure the hardest of hard outcomes that would be almost impossible to design a randomized control trial to answer. And this is particularly problematic, I believe, for imaging compared to a lot of the other studies that we see. After all, we see beautiful trials of 10, 20,000 patients for PCSK9 inhibitors and contuximab and all of these. But that's because pharmacy is backing them and they've got very deep pockets. Whereas whenever it comes to imaging, there's just far less incentive to undertake these massive trials, and a degree of government unwillingness to fund these because they're not generating new income, new treatment paradigms. So I think imaging almost has a unique opportunity to benefit from massive national data sets to try and use these natural experimental designs to answer questions that we might never get the opportunity to do in a randomized control fashion, and to also power them towards hard endpoints rather than having to blend them all together into soft endpoints. And I have to look at the ischemia trial for this, where despite what was it, £100 million and 10 years of effort, halfway into the trial, they had to introduce hospitalizations for heart failure into their outcome because they suddenly realized they weren't going to be powered to meet their primary endpoint at the start of the trial.
Jonathan, you spent a lot of time analysing all of these data sets. I'm just wondering if you could give us some predictions on the direction of travel for this. Will we continue to see coronary CTA requests expand linearly over the next decade? It was 5% growth per annum, I think you were quoting in the paper. Do you think that is going to continue at pace for the near future?
Yes, so the 5% was in global imaging use, but 25% was the growth rate for CT. I think our healthcare system will break if it tries to meet this, but I do think we've got a long way to continue to grow, and that's for a variety of reasons. One, if we look to our erstwhile colleagues in the States, and there was a very nice paper by Stefan Peterson in the Frontiers of Cardiovascular Medicine back in 2021, which did look at the similarities and differences between the US and the UK in the use of imaging. And they showed that there was about a 4-fold greater use of imaging in the States compared to the UK. So I suspect we'll slowly come closer to our statewide colleagues, and this is due to a reduction in the acceptance of risk and uncertainty, both at a clinician level, but also at a patient level as well. So there will continue to be an increased demand. The other reason we'll continue to see an increased demand is we talk a lot about the NICE guidelines in 2016, but actually there was NICE guidelines before that in 2010, and that was the first time the exercise ECG was removed from the guidelines. So we had a lot of growth in imaging following that, and even more following the most recent change, and I suspect it'll be a little while before we see that plateau. But one would expect it to plateau simply because there's only so many patients presenting to the rapid access chest pain clinic. Of course, if Scott Hart 2 or Rabinska comes back positive for screening, then we could be talking about a whole different ballgame.
Jonathan, through this work and the work of your colleagues, as well as work that you've done previously, you've contributed a tremendous amount to our understanding of not just imaging and its trends within the UK, but also the philosophy behind the interplay between advances in cardiovascular diagnostics and how we are treating disease. And for that, truly, thank you. Do you have any final words before we conclude?
I'd just like to say thank you both for inviting me to this. It's been a wonderful hour with you both. I also just want to say congratulations. I remember whenever you both came to the first committee and proposed the Donut of Destiny as a podcast. And to see how that's grown since then is utterly fantastic. And to any of the listeners out there who are in their training or fellowship positions who are considering a future career in cardiac CT, I can't recommend the first committee enough. You get to meet fantastic folks such as Alastair and Praveen here, and you can really see how your ideas can be encouraged, grown, and really come to fruition for years after your time on the committee.
Thanks again, Jonathan, for coming on board. It's been an absolute great podcast and we've learnt so much. And to our listeners out there, thank you as always for tuning in. Remember, if you like what you hear from us, please rate, review and subscribe to us. This helps others out there find our content. Once again, this is the Donut of Destiny. Cheers.